Our next speaker is Dr. Serge Geara. He's a neurologist focusing on mitochondrial diseases, working at NeuRA, funded by a Mito Foundation Clinical Fellowship, working with Professor Carolyn Sue. I found out just now that Serge actually officially graduated as a neurologist yesterday in Brisbane. So I think we can all... So our clinical fellowships are an important way that we make a contribution to making sure we've got Mito specialists in Australia that are learning from other Mito specialists and will be seeing Mito patients and providing important healthcare for them well into the future. Right now, there is more research into Mito than ever before. As we explained yesterday in our session on clinical trials, there are dozens of clinical trials for mitochondrial disease happening around the world and even more new therapies in development than that. But what does that mean for people in Australia? So in this session, Dr. Geara will explain what clinical trials are currently happening, what other clinical research is related and is contributing to clinical trials, and how all of these studies could work together to shape future treatment and care. And it's your chance to hear a little bit more detail about precisely what's on the horizon and what it might mean for you or someone that you love. Thank you. Oh.
Yeah, we'll see. Hello. I didn't pick this picture. It's very big, very zoomed in, but hello, everybody. My name is Dr. Geara, Serge. I might know a few of you through the clinic. But basically, I was asked to talk about medications and things that the trials that are in the space. And effectively, there's a lot going on in the Mito space, but a lot of it is also a bit of a pitch about what we do down at Neuroscience Research Australia, down at Randwick. So what we know is that there is some dysfunction. There's a lot of mutations that happen in Mito disease in the electron transport chain of the mitochondrial pathway, which it ultimately helps us get energy and energy efficiency. And what happens in that situation is that any energy-hungry tissue, such as the brain, which requires a lot of energy, the muscles, the gut, the heart, all of them get affected in a certain way. The problem with mitochondrial diseases is there's multiple mutations, which can ultimately affect people differently. And I know this is something that's well known, but also on top of that, there's the idea that the bad, so to speak, mitochondria can concentrate in any tissue by way of being random. So the manifestations within the same mutation can be different. So 2 generations can have different manifestations. So I wanted to talk internationally what's going on, what we have locally at NeuRA, and then to go from there. So the challenge is, yeah, as we all know, I've actually noted in the last talk, is how people's experience with Mito is completely different, and therefore the symptoms are different. The look, for example, if we say we want to address people's mitochondrial myopathy, it might be different in different people. And there's no way to actually measure the improvement in terms of a blood test or a biomarker. So the look for biomarkers is also important. But now that we understand more the genetics and the physiology of it all, we are trying to target different ways along the pathway to help patients, participants, basically have less symptoms and better quality of life. So we will look at previous approaches, looking at small molecules, potentially gene therapy, and future directions. So as I mentioned, there's lots of causative genes. So Mito is one big umbrella, and we face that when health professionals and families and carers and patients go to the NDIS. You tell them Mito, and they think it's only a vision problem or a hearing problem or a muscle problem, but it actually can be a lot of other things. It's progressive, so right at the moment, we don't have medications that stop the disease in its tracks or make it better. So we're going to be, helping to look, what research is looking at into making it better. And there is a lot of trials that have failed, including one that I'm going to mention, but effectively, there's lessons to be learned from that. So the scientists have looked into very creative ways to look at to treat the symptoms. So instead of just replenishing CoQ10, which is very helpful, but there are other ways to look at tweaking the metabolic system to help best energy come out of the mitochondria, such as enzyme stimulators, gene therapy, I'll talk about a bit later, and drug repurposing, which is all drugs that are coming through that are going to be repurposed for mitochondrial disease. So the first medication is Elamipretide, which was being tested in North Shore, to my understanding, but has that trial has closed. But you'll be hearing about it in the next few months to years. Basically, what it does is the mitochondria, they usually draw it as lines, but it's made of a membrane, and that membrane can be stable or unstable based on the way the electrons are. And this medication makes the membrane more stable. So it's basically like setting concrete into a wall to make sure that it doesn't seep through and then therefore does its job correctly. And by stabilizing this, you don't have the bad outcomes, which is reactive oxygen species, which is an oxygen with one electron on it. And that helps potentially give you better energy production. There's a lot of studies, and it's not only being used in the mitochondrial space, it's also used in macular degeneration and retinal degeneration, which can sometimes be part of mitochondrial disease. But there's a big study recently with Barth syndrome, which is a pediatric disorder, but some patients have it as an adult, which has helped 6-minute walk test and muscle fatigability. So this is the TAS Power, which was done on patients with Barth syndrome. And this was an open label extension, and that was 2.5 year extension. And basically, the blue lines, the blue lines look initially that there's differentiation of the symptoms, but eventually patients all reach the same outcome. So it's helpful in a short term, at least in the first year, to help with symptoms. And it's helped both in muscle function and in lower rate of heart deterioration. And there are other studies, like I mentioned, so age-related macular degeneration or macular degeneration in the RECLAIM 1 and 2, it's been helpful in visual acuity and atrophy of the retina. And then there has been the Power, which has also been used in patients with mitochondrial myopathy. So the place where it might be helpful in almost all mitochondrial diseases is probably fatigue and muscle symptoms. That's probably going to be the place where it's going to have its place. And I'm sure that now that there's the Barth syndrome trial, that this is going to be trialed in different disorders. So that's the watch this space of this. Another medication is called Bio 101 or 20-hydroxydisone, which there's a pathway inside the cell that's called MAP kinase, which usually the mitochondria needs in order to function better. And effectively, it should help the muscle physiology and not just the electron transport chain. So this is also potentially being used in people with chronic fatigue syndrome as a potential medication. However, this is still in its early studies. And there was a SBI-MID study for this medication, and it helped people become faster and more efficient with the 6-minute walk test. And this was one of the first positive phase 2 to phase 3 trials in this specific mechanism in the MAP kinase. The other potential agent is KL133. Basically, in your cell, sorry, again, I'm sorry to get theoretical. There's a lot of oxidation and reduction, so there's electrons being given and taken, and the body responds to a certain level of these chemicals. So if you have more NADH in one place, that will tell you need to make more energy, versus if you have more NAD+, it will tell you please rest, you need less energy. And because the mitochondria doesn't make enough ATP, which replenishes this, that can be an issue. So this medication is felt to help control the lactic acidosis and potentially be effective in MELAS or in people who have stroke-like episodes. And KL133, the reason why I mentioned this medication is because there's potentially going to be a trial. We're awaiting ethics approval. I can't say more, but effectively, if we pass ethics approval, we will be recruiting at NeuRA for patients to get this medication as placebo or medication. And it's been shown, at least biochemically, to increase this. And we assume that this is going to increase energy levels, but also decrease the risk of stroke-like episodes. The only thing is this uses up a lot of vitamin D, so patients need to be screened for vitamin D deficiency and osteoporosis. And there was the Nexus study, which is 3 years ago, which is a phase 1b and phase 2 is still studied in animals or in small group of healthy people. And basically, it showed a favorable safety and tolerability profile. The more you take the medication, the more you have NAD plus, and which is the good thing that you want in order to make more energy. And potentially at NeuRA we might have this study. So watch the space. I will inform Mito Foundation if that medication gets approved, so we can help recruit patients. Another novel agent was REN-001. That's me at a marathon a couple of weeks ago. So I've only been able to run 6 kilometers because I gained a lot of weight training for being a doctor. And the reason for this is I trained a bit more and I was able to finish 15 kilometers at a very slow time. But effectively, this medication was felt to work in a way to train the muscle to become better and be able to get to the finish line by way of different mechanisms. And unfortunately, this medication did not make people walk more. But the idea is that why do I mention a negative trial is because this mechanism of training the muscles could potentially be looked at not only by way of tablets, but by way of techniques like stimulating muscles and things like that. And that has been looked at, but we have better ways to do that. And this might be a way to address muscle symptoms in mitochondrial disease. And then another novel agent is a spark plug. So this is NV354. Basically, the Krebs cycle is where you make the energy, which then gets sent to the electron transport chain, which gives you ATP. And this it makes the Krebs cycle activate again, which is what you need to make more ATP. This is still preclinical, but it's looking like it's very helpful in terms of measuring the biochemical markers in different areas. And this will be probably next year. I don't know if Australia will be involved, but I'm actually going to be looking into this because it's an oral tablet as opposed to injections and things like that. And gene therapy. So people talk about gene therapy all the time. And basically the idea of it is in the usual time, when you have a virus infecting you, the virus itself, outside the envelope, does not do anything. It's the DNA inside of it. So scientists are using this, and clinicians are using this technique to basically say, okay, we can give an envelope that looks like a virus and make sure that it's one that can enter the brain. And we have a colleague with us in NeuRA who is doing it for Parkinson's disease, but basically finding markers that can go to the brain and attach to the right places that we want it to. And effectively, we can put what we want genetically that we want to get the effect to. So deleting a gene, adding a gene, making sure that it's the correct gene that's there without it going to anywhere else by way of testing beforehand that's there. So this, in the next few years, is going to be very helpful for many genetic disorders and might potentially get us to be able to cure diseases, or at best or at worst improve symptoms to a certain extent. And this has been helpful in other neuromuscular diseases like primary muscular atrophy, which has a different mechanism, but we think we can, if we understand the physiology, if we understand the biochemistry behind things, we can do it more. And there's an example of a TK2 deficient mitochondrial depletion syndrome. AAV9 is one vector of virus, and inside of it there's genetic machinery, and it seems to be potentially curative and one-time treatment. I've seen it in motor neuron disease where I worked last year, and it was multiple treatment, so it wasn't as curative as people say it is, but it's also really good to help symptoms or at least stop the disease from progressing. And return of the meds, I say that because we're going to be looking at how different medications affect the mitochondria and potentially use it again. And some of the medications that, for example, cholesterol tablets, some anti-seizure medications might be used, not obviously not valproate, but the other ones, to be able to be repurposed as potential treatment for symptoms in Mito. And I was mentioning the biomarkers, and I've put it here because right now we have a disease that affects so many tissues. We can't biopsy the brain all the time. Muscle might be even hard. A blood test is the easiest, but blood test doesn't give us always the right answer. So the idea is we want to be able to find a way to measure how much is something doing. Like, for example, if you think about your kidney function, we know that if your your eGFR is more than 90, your kidney is functioning well. Less than 60, it's bad, and anywhere between starting to get bad. In Mito, it's very difficult, and that's because the disease can concentrate in the tissues as opposed to somewhere else, and it's different with different symptoms. So this is where I mentioned, again, as I understand Seb has mentioned, the natural history of mitochondrial diseases study. Effectively, we're collecting samples from patients and collecting clinical information from patients with mitochondrial disease. We're looking at the progression over time. We're looking at the clinical progression, but my specific project with the Mito Foundation has been to look into something called circulating mitochondrial DNA. So when the cell breaks down, there's mitochondrial DNA that goes out, and that's a marker of a dead or non-functioning cell. And the idea is it could be a final pathway because despite the fact that it can start in the muscle, it can start in the heart and the gut, it goes to the blood. And once it gets to the blood, we know that that's a final common pathway. And we're going to see if patients with more severe disease, if they have higher number of these circulating mitochondrial DNA, which means dead cells or products of dead cells. So that's one. At the moment, we have about 125 patients and 71 patients with mitochondrial diseases, which is relatively a big number. And we want to look at biomarkers, progression, natural history. We wanted to look under the cell to see what mitochondrial cells look different, potentially for gene therapy. So it's a sort of all-encompassing umbrella study that we're hoping that people can come and join us with. So just a consideration. You can talk to me about it later. And then another medication that we are also involved in is zagosygwat, which is basically like when you get a stroke, you take aspirin to not have a stroke again. And zagosygwat works effectively in the same way by making sure no more tissue dies or no more tissue starts being dysfunctional in a different way by way of arginine, which helps keep your vessels open. And effectively, we have, it appears to be tolerated in phase 1 and phase 2 studies. But at NeuRA, we finished our recruitment for October, is my understanding. But there will be open label studies, so we'll talk to people about it in the near future. So in conclusion, there's so many medications that are coming through in the next few months to years. Keep an eye out on things. Always ask your doctors about trials. And even if they don't know about it, ask them to research, because there might be a place that will be done. I'm pretty sure I don't know every trial in Australia that's happening, but at least I know the ones in NeuRA. And if you ask me and I don't know, I'll get back to you, and it might be helpful to get a potential treatment. I'm sorry that I didn't look at potential like lifestyle changes, because I know this has been looked at multiple times. I'm hoping that we'll be able to get, tablet treatments as well. And gene therapy, I think, is going to be the next frontier in a lot of these neurodegenerative diseases. And we'll have to think about matching the right drug to the right patient. I think these medications will fit different symptoms and different manifestations. And we are all a part of it. Thank you so much.